So this is chapter 9, recording 3. The next thing that we're going to want to do is assess the level of consciousness, also called the LOC. This is where we're going to determine how with it the patient is. This gives us a good clue into their neurologic and physiologic status. So if we're talking about this very, very generally, we have a couple of different categories that we can place the patient into. Unconscious, we can place them into conscious with an altered level of consciousness, or we can place them into conscious with unaltered. There's more to this that we'll go into, but these are kind of those basic principles that we can put them into. Assessment of an unconscious patient focuses mainly on airway, breathing, and circulation, because you're not going to really be able to form any more of an impression about the mental status of your patient or collect any sort of history from them. And because they are unconscious, they can't adequately protect themselves. So you want to be a little more vigilant with them. If they continue to be unconscious even after time starts to pass, that should be an indicator that there is something severely wrong with this patient and that you should assess them more thoroughly and that they are more of a critical patient. Conscious with an altered level of consciousness is generally going to be due to inadequate perfusion. Remember, perfusion is cells getting enough blood to get enough oxygen so that they can function at their normal level. If there's inadequate perfusion, then they're not getting as much oxygen to the brain. The brain needs to be very oxygen rich for everything to work the way it's supposed to. There are other causes of altered level of consciousness. This could be medications, could be drugs, alcohol, poisoning, could be some sort of neurologic disease such as a stroke. To assess for responsiveness, we have a mnemonic. This is called AVPU. If your patient looks at you and responds before you even say anything, so you walk in the room, they look at you, their eyes track, they're watching you come up, they may speak to you without you actually initiating contact, then the patient is awake or alert. If the patient is responsive to verbal stimuli, they may have their eyes closed and you talk to them and now all of a sudden they open their eyes, or they may have the lights are on, nobody's home stare going on, but as soon as you talk to them, they're able to respond back to you, and then typically they're going to go back to their previous state if you're not talking to them adequately. Like if you're doing an assessment, you're writing, they tend to revert back to that other state, and it takes you talking to them again for them to respond to you. Responsive to pain, so the patient doesn't respond to your questions, but if you do something to them that should be painful, they tend to go ahead and respond to that. They cry out, or they move to pull their hand away if you're doing a nail bed pinch. So the last one is unresponsive. The patient doesn't respond at all. Typically when a patient is unresponsive, they don't have a cough or gag reflex also. Sometimes they do, and if they do, then they're not down as far as you think they are. If they don't have that, they really cannot protect their airway. On the screen is some options for how to test for painful stimuli. You can pinch an earlobe. You don't want to do that in somebody that has trauma. You don't want to pinch the neck muscle in somebody that has trauma, because what they're more than likely going to do if they're responsive to pain is they're going to pull their head away. Press down on the bone above the eye. That's pretty painful. Taking your fingernail or a pen or something and pressing it into the base of the fingernail closest to the finger, kind of where that little light colored half circle is, press down there with that. That tends to hurt and they'll pull their hand away. You can take your knuckles or your trauma shears and rub them on the sternum, called a sternum rub. That is extremely painful. You don't want to cause injury to your patient, but you want to see if they've got a little bit going on. After you assess the level of consciousness, you want to see how oriented they are. So they can be A&O times 4, or they can be A&O times 0, or anything in between of there. In order to tell what's going on with the patient, you ask them their name, where they're at. You can ask them to orient themselves in time. So generally, I start with the approximate date, the date of the week. If they can't answer that, I back up to the month. If they can't answer that, I back up to the year. Or if they can't answer that, I ask them who the president is. And then can they tell you what happened? So if a person is A&O times 4, they know their name, they know where they're at, they can tell you approximately what either date, time, year, etc. it is, and then they can adequately describe the event and what happened. Sometimes if a person loses consciousness because of whatever has happened to them, they may know who they are, they may know the year, but they don't know where they're at or what happened. We can assess to see if somebody has lost consciousness. If, we say, do you remember what happened? And they say, yeah, no, I remember. And you say, do you actually remember the cars hitting? And they're like, well, no, I guess I don't. Then there's a possibility that they had some sort of loss of consciousness. The trying to determine if they are responsive or not for the orientation test, it evaluates long-term memory, intermediate-term memory, and short-term memory. So long-term would be, who are you? The intermediate memory would be, where are you at? And general time questions. And then short-term memory is what happened. So you're checking everything there. It's more often that a person is going to lose short-term memory or have a minor lapse in short-term memory than they will with the other two. Any deviation from knowing who they are, where they're at, time, and then event, or any deviation from being alert, the patient is considered to be in an altered mental status. Now, some patients may be altered at their baseline. So whenever somebody's altered, one of the questions we always want to ask is, okay, is this normal for this patient? Rather than just assuming that there's something wrong with them. So we're going to identify and treat life threats. Any sort of life threat obviously can quickly lead to death if it's not fixed. Conditions that cause sudden death: airway obstruction, respiratory failure, respiratory arrest, shock, severe bleeding, and primary cardiac arrest. In most cases, you're going to begin with airway, then follow that up with breathing and circulation. When a patient's in cardiac arrest, you're going to do pretty much a quick once-over to see what you can identify, and then you're generally going to start with compressions first, then airway and breathing. When a person goes into sudden cardiac arrest, most of the time their body reacts to take a last breath or a gasping breath, just kind of like when you're going to jump in the water and you go, your body tends to do that as a physiologic means to save yourself. And so if we start with compressions, they've already got that air. And then we already talked in the respiratory section about having dead space where air is just kind of hanging out in your lungs. It doesn't get exchanged and it doesn't necessarily go out of the body. It's just kind of hanging out there. So you always have a little bit of reserve. And so we would rather start circulation and then worry about the others. This is a very quick sequence, mind you. For assessing the airway, you're first going to look for signs of airway obstruction. Sometimes the easiest way to prevent an obstruction is positioning of the patient. The most common airway obstruction in a patient that is unconscious is the tongue, especially if they're laying down on their back. Their tongue has a tendency to relax and slide back into their airway. Tilting their head back if they're not a trauma patient, or sliding their jaw forward, and we'll go into this a little more, can pull the tongue out of the way and make it so that their airway is open. Then you want to make sure that the airway remains that way. So open, patent, or self-maintained. If a patient is responsive, talking to you, crying, they have an open airway. So we don't generally need to do anything more than that. We want to watch and listen closely to how the patient speaks, their rhythm of speaking. If they have to stop between words and take breaths, the less amount of words that they can get out, the worse that their problem is. When you identify an airway problem, you're going to stop right there and try and mitigate that problem or take care of it before moving on. Unresponsive patients, that's going to be the first thing that we do. The jaw thrust technique is what we use when we suspect a patient has some sort of potential neck or spine trauma. This won't work on somebody that's responsive because A, it hurts, and B, their muscles are actually going to hold their jaw in place. But what you end up doing is you put your fingers on kind of the angle of the jaw or on the cheeks. You put fingers behind the angle of the jaw, and then you pull forward. So some fingers on the cheek, other fingers on the angle of the jaw at the corners, and then you're just gonna slide the jaw forward. Obviously, as I'm sounding weird, I'm doing it on myself because why not? But in a person that's conscious, it hurts. It doesn't feel right. So that might be one way to do it if your patient's unconscious. The other is a head tilt chin lift, where you actually put fingers on the forehead, fingers on the bony part of the jaw. Everything is going to be with bones. You don't want to put your fingers in what I call the little turkey gobbler underneath of their chin, because then you can actually force the tongue into the airway. So on the bony part of the chin, on the forehead, and then just tilt their head back. This will tighten up some of those muscles and pull the tongue out of the way, which is ultimately what we're trying to achieve there. Signs of obstruction in unconscious patients. This may mean that they have something as simple as blood. Sometimes people tend to throw up when they get hurt. So it may be vomit that you need to suction out. If the patient has obvious trauma, blood, or obstruction, we need to try and clear it if at all possible. Some people that take a blow directly to the mouth might have broken teeth that we're going to want to suction out as well. Any sort of noisy breathing. So if they're snoring, that's typically going to be the tongue. Bubbling, gurgling tends to mean fluid, and so a little suctioning. Either they have spit pooling there that they can't swallow because they're unconscious. They may have blood. They may have vomitus. If they're breathing extremely shallow or absent, that could be that they've got something in the airway that air is not able to go around. And so we're going to try again. The first thing that you'll do if you don't see an obvious obstruction to the airway but the patient is not breathing normally is you're going to assess how you are opening the airway. Maybe you have them tipped too far. Maybe you don't have them tipped far enough. So then you're going to reposition the airway and see if that makes a difference. If it doesn't, then you want to assume that there's something else going on. And we'll stop here and continue in the next.